Hi, Ankur.
Sir, good evening.
Good evening. Good evening. So nice to see you.
Nice to see you, sir. How are you?
I'm fine.
Good evening, sir. Sorry, sir, I couldn't hear you.
I'm Dr. Manish Mehta from Ahmedabad, EB member PIDA.
Okay, sir. Good evening, sir.
Oh,
Good
hi,
evening.
Dr. Manish. मैं
Hello, sir.
चंद्रमोहन हूँ पटना से.
Yeah, thank you.
Good evening,
Thank
Dr.
you, sir.
Ankur. Good evening, Chandramohan
Good evening,
sir.
sir.
Good evening, Manish.
Good evening, sir.
सर मैं एक बार अपनी स्लाइड शेयर करके देख लूं if everything is all right.
Yes,
check
yes,
कर लो.
definitely.
I'll just check, sir, एक बार.
Needed.
Is it okay? Is it? I'll go to the slideshow. Can you see, sir?
Yeah, it's visible. You can make it full
Okay, and
screen.
it's moving.
Yeah,
Yeah,
it's moving.
fine. Yeah.
It's in the full screen, sir.
Yeah, it's full screen.
Okay, perfect. Usually, how many attendees do we expect, sir, in this webinar?
Around 100.
Okay, sir. Okay. And can they interact live or they can just ask questions from the chat box?
Chat box. Yeah, some
Chat
of
box.
those who are on Zoom, they can directly ask. But that
Okay,
will
sir.
be around 15-20 people, I believe.
Okay, sir. Okay.
Manish will be better able to tell you.
Yes, sir.
और चंडीगढ़ में सर्दी चल रही है, खत्म हो गई?
सर आज रेन हो गया फिर से. कल तो गर्मी हो गया था, बट आज रेन हो रही है. तो और वहाँ
तो बर्फबारी चालू हो गई.
हिमाचल में फिर से थोड़ा सा स्नो हो गया है, तो इसलिए फिर से थोड़ा सा कोल्ड हो गया आज.
अच्छा है, आना भी चाहिए थोड़ा. इस साल बहुत कम दिन सर्दी पड़ी.
यस ट्रू. बट अब खत्म होने वाला है सर. आई थिंक मैक्सिमम अब 1 more week and then winters will be gone. How is it there, sir, in Patna? Is it cold?
मजेदार बात है कि पटना में इस वक्त बहुत कम दिन हो, 1 वीक की सर्दी थी. और नॉर्मली
Okay.
विंटर्स में हमारे मॉस्किटोज खत्म हो जाते हैं. इस साल वो मॉस्किटोज खत्म ही नहीं हुए. इस साल वो कंटिन्यू रहेंगे.
Okay. The
ग्लोबल
mosquitoes have evolved, I think.
हाँ, नहीं वो जो है ना कि फॉर एटलीस्ट 1 वीक टेम्परेचर सब 10 हो जाता है तो वो गायब हो जाते हैं. इस साल वो सब 10 गया.
हाँ, बिल्कुल सर.
Good evening, Dr. Bhaskar.
Good evening. Good evening.
Good evening, Dr. Manish. Thank you so much, Dr. Manish, for taking over.
Good evening.
Hi, Dr. Chandramohan.
Good evening, Chetan.
Good evening.
All stalwarts are there.
Arey, nahi. Like we are the grassroots level workers here. First, at least me and Manish. Because
The Ankur, hi.
hi,
Hi, sir. Hi, sir. Hi,
Chandramohan.
Dr.
hello,
Ankul.
hello, everyone. Hello,
Chandramohan
hello,
ji.
sir. Hello.
Hi, sir.
Yeah.
Namaste.
Good
Pramod
evening, sir.
sir.
Bhaskar sir.
Pramod sir is there.
Namaste.
Very humbled in all these greats.
Arey,
सर कॉन्ग्रेचुलेशंस, आप फिर से स्पीड में जा रहे हो सर, कॉन्ग्रेचुलेशंस।
हमेशा का है, उसमें नहीं।
नहीं, आपके मैंने 5-6 देख लिए एब्स्ट्रैक्ट।
क्या जितने हो सके उतने भेजना है। ट्रैवल ग्रांट मिल जाए तो अच्छा। भास्कर सर, आपका
Yes,
क्या
sir.
हुआ एब्स्ट्रैक्ट का?
Accept हुआ.
Great. So you are accompanying there.
No, I have not. There is some more programs together. So I have to adjust and see
So
now.
you will be joining online.
Yeah, probably. Because the first week of first 10 days I'm going to UK. First May 1 to 10. So it becomes a double burden. So I'm thinking we'll take a decision in a week.
So you can have a 15 days Europe tour then by that time to fill in the gap.
Whole of May.
Sir, you can join as Kulkarni sir has dared Count Dracula कि I'm coming. How you think of yourself?
बाद में आया तो सब खत्म. ಇವತ್ತು ಜಸ್ಟ್ ಇಂಟ್ರೊಡ್ಯೂಸ್ ಮಾಡಿ 5 ನಿಮಿಷ ಮಾತ್ರ. ಸೊ ಆಮೇಲೆ ಪೇಷಂಟ್ ಬಂದರೆ ನಾನು ನೋಡು 5 ನಿಮಿಷ ಮಾತ್ರ. ಅದ್ರ ಮೊದಲು ಬಂದರೆ ನೋಡುವ. ಸ್ಟಾರ್ಟ್ ಆದ ಕೂಡಲೇ ಒಂದು 5 ನಿಮಿಷ.
good evening, Dr. Mandar.
Good evening, Chetan bhai. Good evening. Good evening, everyone.
Good evening, Mandar.
Yeah, good evening,
sir.
Good evening, sir.
Hi, good evening, Dr. Mandar.
Yes, good evening, sir.
Nice to see Mandar after a long time.
Yes, sir. Yes, sir. We met at the Pentagon before that attendance.
Analyst in some call.
Yeah, yes, sir. Yes, yes.
So nice.
Thank you, sir. Thank you, sir. Thank you.
Pramod sir,
Yes, please.
did you have a word with Rajesh sir about timing and everything?
No, I didn't call him personally.
Okay, fine.
Hi, Chetan bhai.
Hi, yes, Yashwant bhai. How are you, Yashwant?
यशवंत भाई, गुड
फाइन फाइन।
इवनिंग।
कौन? चंद्रमोहन साहब?
सर बिल्कुल सर, नमस्कार।
चंद्रमोहन भैया।
यशवंत गारू,
काय को गारो, काय को भाई?
क्या
गारो काय
पता
को
है?
ये?
ऐसा बोलते हैं ना, यशवंत गारू नहीं बोलते?
तेलुगु में तो
काय
गारू
को,
है।
काय को चेतन गालियां दे रहा?
अरे अच्छा ऐसा है. So is it not just like a भाई?
Yeah.
नो नो नो,
Then
गारो बोले तो
More, I think more than by.
इट्स ए जी।
अच्छा, is it?
मोर देन भाई।
अच्छा. Okay, that's why
इट्स
he's
ए
telling guy.
रेस्पेक्टेबल।
Sorry.
No, you're not. You're not
सर
wrong.
भास्कर सर नमस्ते।
I'm not wrong now. Okay, fine. Bala sir has joined, no? Yeah.
चेतन भाई फिर एक मर्तबा अपना रिमाइंडर आया, ये प्लीज सेंड द मैसेज नंबर ये बोल के।
किसका?
एक कैंडिडेट का, शी हैज पुट व्हाट इज माय नंबर ऑफ आईडी चैप्टर बोल के।
It has been communicated through Somnath. Whoso whatever message comes, no. Usually I divert it to Somnath. He connects the and follow up has been done.
Can you share me the number of auditor, because my auditor will speak to the auditor on that.
I will share. I will share.
हाँ?
Yeah,
एक
sure.
मर्तबा ऑडिटर बात करे तो ना खत्म हो जाता वो।
Yes, I will.
Did you call Dr. Rajesh?
No, I have not called.
Just find out.
I'll just call.
डॉक्टर नर्मदा हैज ज्वाइंड।
चंद्रमोहन भाई कब है आपका पेडिकॉन?
8th 9th मार्च है सर।
Good evening, sir. Good evening, sirs.
हाय, गुड
Oh,
इवनिंग।
good evening, Narmada ma'am. Good evening, Narmada ji.
Good evening, sir.
मनीष भाई नमस्ते।
Good evening, sir.
नर्मदा मैडम might be in OP.
No, sir. Today no OP. Here is a local function here, sir. We call
Okay,
it
okay.
the Shivratri. It's a very grand occasion for them, sir. That's why.
Okay.
So we have no today. It was no OP.
वी हैड शिवरात्रि यस्टरडे।
No, after the Shivratri, they have some local function here.
They'll break the uh, fasting as well as night they don't sleep na.
No,
So
Sir.
traders and others
not
go.
that, sir. They go to the Shamshan and do some puja there, sir.
Okay,
Yeah,
okay,
Rajesh sir
okay.
has joined.
Mm.
Rajesh sir has joined and then left. I don't know.
प्रमोद सर भी आ गए।
हाँ, वो तो है. Sir आ गए.
सर सबसे पहले।
So 9 o'clock, I think we should start.
अंकुर जिंदल is in PGA. Ankur sir is in PGA.
Yeah. He's a,
Sir, yes, sir.
he's a,
Hi sir, Ankur sir.
he's a budding
Hello, sir. Hello,
immunologist,
sir.
not budding, already budded.
But it, sir.
Already budded.
And
Ankur
very
sir.
very specific to
But
HAE. Hereditary angioedema is his own child here.
yes, sir. Thank you.
Dr. Bhaskar, shall we start?
Yes, it's 9. Yes, you should start.
Dr. Rajesh sir
Dr.
had joined,
Rajesh
but
is-
he joined. I saw him, but then I think he disconnected.
No, just let him join first.
Yeah.
Yeah.
Yeah, he has joined. Yes, sir. Good evening, sir.
Hi, good evening.
Yeah, thank you, sir. Thank you, sir. So I think
Good
we can
evening,
start
good evening,
now.
sir. Dr. Rajesh Udani, good evening.
Good evening, everybody.
Good evening, sir.
When do
Namaskar.
I come out?
Pardon, sir?
My talk is in the middle somewhere, no?
So that Dr. Pramod sir will be able to say.
Okay.
We will just start it and then.
Yeah, no problem. I'm not in a hurry.
Okay, sir.
12 to 14 minutes, sir.
Okay. Anyways, good evening, everyone. Welcome all of you to yet another episode of Super 11. That Super 11 series has been started last year under the leadership of Dr. Arul Rangnath sir, and that is a brainchild of our own Dr. Bala Subramaniam sir. So welcome all of you. And first, I'll request Chairperson Dr. Bhaskar Shenoy to say a few words.
Good evening, everyone, respected faculties and my team members. It's a privilege to preside over this program. In fact, today's webinar is a unique one. Always we used to talk about infection. Today we are going little beyond infections, and always we used to have ID specialists. Today we are going to have beyond ID specialists, maybe a neurologist, a immunologist, a hematologist. And these are the common problems that we generally see, wherein the most of the non-infectious conditions, they behave like infections, and vice versa is also true. And in such cases, we have a lot of dilemmas. And it is not like a horse which has been directed towards one direction. We have to look across, look both sides. So that is the theme of today's webinar. It is beyond antimicrobials approach to common post-infectious immune complication. And probably this will definitely stimulate us to think beyond infections in such complicated situations. With that brief introduction, I welcome the all the panelists today. In fact, I should thank Dr. Pramod Kulkarni for initiating this great idea. And then thanks Dr. Brajesh Udani, Dr. Ankur Jindal, Dr. Chandramohan, and for joining today's program. Hope this will be a fruitful meeting. Thank you.
Thank you, Dr. Bhaskar. Initially we thought of discussing something which is happening in and around Pune area. And so that was a discussion which started because we saw some of the cases of GBS following some infections. So we wanted to discuss it out. But then we talked to Dr. Pramod Kulkarni. He said that this can be a part of the immune complication of many of the infection. So why not to cover it as a whole? And that's why he suggested that to have a panel of experts of different fields so that we can cover the whole topic in a proper perspective. So I'll request, as we know that we have a faculty today, Dr. Pramod Kulkarni. He's a very, very well-known ID specialist, and he'll be moderating the session. And then I'll request Dr. Pramod Kulkarni, sir, to take over and start his panel discussion. Thank you.
For that, Dr. Mandar Deshpande.
Yeah. Mandar is
I welcome him also.
Yes.
He is there in the heart, but he didn't come.
Yes. And I welcome Dr. Bala Subramaniam, sir, as well as Dr. Vijay Evle, sir. And Dr. Pramod Kulkarni, sir, you can just, stage is all yours.
Good evening and welcome, friends. As already said by Chetan, we always deal with infections. And infections are essentially associated with the other unseen or less seen half of immunity, which is usually positively involved for us. But over last few decades, we have seen there is, with the increasing exploration of the field of immunology, as well as its different roles and recognition of new clinical immunological syndromes associated with the common infections, we all are now perplexed with the role of immunity. So it's a need of our to review the role of immunity with infections, especially where we are concerned with the post-infectious or para-infectious immune complications of common infections. So that is the focus today. And as already opened by Chetan, we will be starting with the commonest, the current problem mainly in Maharashtra and around, as well as reported from other areas of India, which is Guillain-Barré syndrome, which is the prototype immune complication of preceding infection. Not only that, we have another important area, that is hemophagocytic lymphohistiocytosis, a common diagnosis done by everybody, including the peripheral places, and which needs a specific recognition, early recognition, and specific therapy. So these are the two main focus areas of today's discussion. We also will be touching some other important ones like the hyperinflammatory syndrome, capillary leak syndrome, and the other hematological immune issues associated with that. To enlighten us about the increasing role of immunology and to tell us about the basic applied immunology, I invite Dr. Ankur Jindal to address us about the immunity and its role with the current evidences and current concepts in the causation of these post-infectious immune complications. Welcome, Dr. Ankur Jindal.
Good evening, sir. Thank you so much. Thank you so much to the Pediatric Infectious Disease Academy for inviting me for this very important webinar, and as has been highlighted in the introduction by Dr. Pramod, Dr. Bhaskar, that this is a very important topic. We often think about infection, but we sometimes forget that infection is just one part of the entire story, and it also leads to a lot of side complications which we have to manage differently, just not by treating the infection. Of course, treating the infection is important, but it's also important to manage the complications that arise as a result of that infection. So can you see my slides? I'll present a few brief slides to give my understanding about immunological aspects of these post-infectious immune problems in children. So can you see my slides, right?
Yes, yes.
Okay, so it's very important to know that these post-infections immune complications, there are several of them, and some of them are written here, and some of them have been highlighted by Dr. Pramod, and many of these are being increasingly recognized now, and this has led to a major change in the management paradigm of these conditions, and we'll see through this webinar today how identification of a specific complication or of a specific immune complication lead us to decide a precise treatment for that particular complication. So some of the conditions that we will discuss today in detail are multisystem inflammatory syndrome in children, which we started noticing post COVID-19. Although this is something which is now disappearing since we are not seeing any more COVID-19 infection, but the understanding that we developed from multisystem inflammatory syndrome in children can actually be used in many other such conditions that we see day in and day out. So we'll also talk about a lot of post-infectious neurological syndromes and Guillain-Barré syndrome. Of course, I'm not an expert on neurological syndromes, but we have experts in our panel who will discuss about especially GBS, which is kind of increasingly being recognized in many areas in India right now. The other spectrum is HLH, which could be infection triggered, which could be malignancy, which could be triggered by autoimmune diseases, and therein we call this as more macrophage activation syndrome when this is associated with autoimmune diseases. And a rare and uncommon spectrum is primary or familial hemophagocytic lymphohistiocytosis. We'll talk about some aspects of it. And then there are several post-infectious autoimmune diseases which can involve hematological system, can lead to vasculitis, can also involve musculoskeletal system. For example, you all know about a post-streptococcal reactive arthritis or acute rheumatic fever, which is a post-infectious complication that typically affects musculoskeletal system and heart. So with this introduction, I will also be giving a few case scenario, very brief case scenario, to understand the pathophysiology better. And this is the case that we saw during COVID-19 pandemic, and I'm sure you all have seen such cases during that time. So this is a 7-year-old boy who had fever, rash, red eyes, swollen lips, and he was hypotensive when we examined him. He had tachycardia, hepatomegaly, altered sensorium. His investigation showed he had anemia, and as you can see over here, he also had lymphopenia, thrombocytopenia. His ESR and CRP was high. His 2D echocardiography showed a low ejection fraction. His pro-BNP was very, very high, and his serum ferritin was also very, very high. So this was a typical case of multisystem inflammatory syndrome that we see in thousands at that point of time. Although this is disappearing, as I said, but the understanding that we developed from this syndrome is still very, very useful for us in today's practice. So there have been several hypotheses that has been proposed for the pathophysiology of multisystem inflammatory syndrome in children. The ultimate outcome is a cytokine storm. As you can see, as in this figure, this is like a storm. A lot of cytokines produced in a very short span of time, leading to a very massive inflammation in the body. And there are several hypotheses which include superantigen theory, also true for many other infectious infection, other than COVID-19 infection. It's also important that persistent exposure to infection, and this also happens in many other viral infection, that if you have persistent exposure for a very, very long period of time, which was very typical for this infection, can also lead to persistent inflammation. A leaky gut was another major hypothesis, which was very peculiar to this particular infection. And this infection was also known to produce autoantibodies. But as I said, all these, all these hypotheses, all these, major, pathophysiology going on in the body ultimately led to cytokine storm, which was leading to all the clinical manifestations in the patient. There was an ongoing debate all the time whether MIS-C is a separate entity or it is more like Kawasaki disease. So this slide shows the differences between these two entities. MIS-C was definitely something which was different from Kawasaki disease, as these children were usually older as compared to relatively younger children in Kawasaki disease. More GI symptoms were seen over here. There was increased myocarditis, cardiac involvement, but not coronary artery involvement as compared to Kawasaki disease. These patients had high ferritin. They typically had leukopenia and lymphopenia and thrombocytopenia. And the treatment was slightly different. Over here, we were using a lot of steroids as compared to very less use of steroids in typical Kawasaki disease patients. Now coming to another example, this is a 6-year-old boy, resident of Shimla. I saw this boy a couple of years ago. He had fever, poor weight gain, jaundice, left arm swelling, and rash. He had pallor, he had jaundice, he had fatigue and ecchymosis, as you can see in this picture, and hepatosplenomegaly. His family history showed that he had lost another sibling of his at the age of 6 months, and this was an unexplained death that has happened. It's a very positive family history, and this patient had anemia, thrombocytopenia, leukopenia, and very severe neutropenia, as you can see over here. Also had transaminitis, high ferritin, triglyceride, and high triglyceride and low fibrinogen. Now, this is a very typical presentation of HLH. But this could be secondary HLH or primary HLH. We investigated this patient, and we'll talk about this in the panel discussion further, that how to differentiate between a primary HLH or a secondary HLH. And over here, I'll talk briefly about the pathophysiology of HLH, be it primary or secondary. This patient, when we investigated, he was found to have low perforin expression on flow cytometry and a mutation in perforin gene. And over here, you can see in bone marrow slides, there is hemophagocytosis. So, as I said, the ultimate result is cytokine storm. And over here, you can see a normal pathway wherein a viral infection lead to activation and expansion of cytotoxic T lymphocytes. But once the infection is cleared, once the infection settles, this immune response has to be taken care of by our own immune system. And this happens normally, but in patients with, for example, macrophage activation syndrome, or in COVID cytokine storm, or many other sepsis-associated cytokine storm, this elimination of antigen-presenting cell macrophages and cytotoxic T lymphocytes is impaired. The mechanism is slightly different, but the end result is development of a cytokine storm. So this is slightly complicated. This is how a patient with the primary HLH presents, and this is a cytotoxic T cell and its major function is to kill the target cell which contains viruses. So the cytotoxic T cell has to kill the target cell, and the killing is by perforin and granzymes through these vesicles which are released from the surface of cytotoxic T cell. Now, when these, for these perforin and granzyme from cytotoxic T cell to come to the surface and to be released from the cell and to kill this target cell, there is a process which is involved. And as you can see over here, these vesicles, they have to be sorted, they have to be polarized, they have to have a docking process, they have to have priming, and then have to have fusion to the cell surface, and then finally they are released. And there are several enzymes and several genes which are involved into this process. They can be RAP27, MUNC, syntaxin, and defect in any of these genes or any of these proteins can lead to primary HLH. And this table shows, some of the gene defects that are known to cause primary HLH. These can include perforin, UNC, syntaxin, RAB, and there are several genes which are also associated with EBV-driven HLH. So this is how the pathophysiology of primary HLH evolves. And because these patients have a genetic defect, if you do not treat the underlying cause by bone marrow transplant, these patients will continue to have HLH. As we see, this is the International Union of Immunological Society's classification of immune deficiency diseases. Now, these diseases fall into group 4, called as diseases of immune dysregulation. And I'm not going to talk about each one of them. There are more than 50 defects that have been identified. So these include, as I mentioned, perforin, MUNC, many other. And, so we can just skip, and you can see there are several of these gene defects that have been reported to cause HLH and immune dysregulation. So this is the last case that I'll show. So this is a 6-year-old girl we recently saw 2 weeks ago. She had fever, cough, pain, bluish discoloration of both feet. As you can see in this figure, she presented with gangrene, and she also had decreased movement of the left side. And this was as a result of a stroke in the brain. Now, if you see the chest X-ray, she has a pneumonia. Now, this is the only infection that she's having. Rest everything that she's having is a complication that is developing because of this particular infection. And as you can see, she has a big stroke over here. She has this, thrombosis developing in the large, arteries in the lower limbs, and she has these splenic and the renal infarcts. So what we had in this patient was, this patient had anemia. This patient had over here you can see these very high mean corpuscular volume, very high MCH and MCHC. So this was a very, very typical case of cold agglutinin disease. As you can see, the cold agglutinin titers are very, very high. And over here you can see the RBC clumps in the peripheral smear. So this was a cold agglutinin disease triggered by mycoplasma infection, which was leading to thrombosis. So this was a post-infectious complication developing in this patient. As you can see over here, cold agglutinin disease contributes about 10 to 25% of all cases of autoimmune hemolytic anemia in children. And unlike adults, wherein it is typically associated with malignancy, in children it is typically associated with mycoplasma pneumonia and Epstein-Barr virus. So it's a complement-mediated disease leading to immune complex formation. And the management is hugely supportive, and also by giving intravenous immunoglobulins. This is another case that we saw a few years ago. It was published, another case of mycoplasma infection triggered cold agglutinin disease presenting with a gangrene like this. So these cases just suggest, infection, is not the only thing which is causing damage in the body, but it is leading to a lot of immune complications, which could be driven by cytokine storm, by formation of autoantibodies, by formation of immune complexes. There are several mechanisms, and it is important to identify so that you can identify the precise medicine. And we'll talk about these therapies in the panel discussion, but just for the sake of presenting what are these specific cytokine targeted therapies, the major important cytokines which are involved in a cytokine storm like situation are interleukin-1, 6, interleukin-18, and interferon gamma. Fortunately, we have therapy for all of them. Some of them are available in India, some of them are not available in India. JAK-STAT inhibitors are increasingly being used in these patients to dampen all these cytokines. And I think we'll discuss about all these therapies as we go further in the panel discussion. So with this, I stop sharing and
Thank
we
you
look
very
forward
much
to have comments.
for giving us the insights about the causation of the immune problem. Do we really have any increased propensity or possibility of immune complications or particular organism being more immune active for these problems amongst the bacteria, viruses, parasites? So any
Yes, sir.
particular organism which have high risk of immune complications?
Right, sir. So, sir, we already talked about COVID-19 infection, and as we already mentioned its properties that this infection has a propensity to lead to cytokine storm, lead to a lot of autoantibody formation, also has a propensity to persist in the body for a very long time, leading to immune system activation for a very long time, and propensity to develop cytokine storms. This is one of the very important infection which causes immune complications. We've seen several immune complications related to mycoplasma infection. Epstein-Barr virus is one which leads to several autoimmune complications and HLH. So there are some infections which definitely have propensity to develop immune complications more often than the other infections.
Thank you very much, Ankur sir. Now, after this introduction about the immunity and immunological issues, let us go to our current problem faced by most of us in Maharashtra, that is GBS. And we are blessed to have Dr. Rajesh Udadi to guide us and tell us about the current scenario and insights about GBS. We all manage GBS over decades now, but let us learn the updates and the key points from Dr. Rajesh sir. I request Dr. Rajesh sir to tell us about the GBS, the current issues, and the relevant applied key points to be remembered by us, especially the common pediatric practitioner. Welcome, sir.
Yeah, thank you. Good evening, everybody. Are we having a discussion or are we having some slides and all that? Yeah, so you ask me questions, I'll answer. That's what I'm saying.
Yes, sir.
So
Basically, let us please know what is GBS, what's the pathophysiology, current epidemiology, the initial overview, when to suspect it, and what's the natural course and outcomes of GBS in pediatric with current updates.
Okay, I have a couple of slides which I've made from my old, on the pathophysiology, because that's obviously easier to understand with cartoons rather than just mentioning it. But basically, Guillain-Barré syndrome is an acute inflammatory polyneuropathy, and essentially it is the most common neuropathy after the extinction of polio being after we got rid of poliomyelitis is the most common cause of AFP. And in fact, there are many atypical variants, but the two main types of disease which you have, acute inflammatory demyelinating neuropathy or AIDP, and the other one is AMAN, which is acute motor axonal neuropathy. And these two are approximately equal in incidence in countries like India, maybe Southeast Asia, but not so much in the West. In the West, you have mainly AIDP. About the incidence, I don't know exactly. It's about 0.3335 or something per 100,000. But basically, there are certain things which can increase the incidence. For example, you had an epidemic in Pune, probably because of contaminated water, and maybe there was, certain bacteria, certain viruses trigger of GBS. And
Sir, sir, can you switch on your video, please, if possible?
Oh, sorry, I'm sorry.
Please, thank you so much, sir.
Yeah, so basically this Pune episode occurred because of contaminated water. Now, whether it was Campylobacter jejuni or there was some E. coli, I'm not very sure because there were lots of different reports. But essentially, those who drank that water, it triggered GBS in those patients, and there were, I think, a couple of deaths as well. The one important thing about AMAN and AIDP is that they are sort of one is seasonal, and that is usually the AMAN, which comes in certain months of the year, and it basically comes in crops. While the other one is AIDP, which is seen the year around, and there is no seasonal variation. I'm not sure which particular season we see it more, but generally post-monsoon is the time when I've at least seen these things. Maybe it's the increased incidence of viral infections. Now, the pathophysiology, I think I just share my slide just to sort of make it a little easier to understand. Yeah. Can you see it?
Yes, sir. Yes, sir.
I just so this is, I've taken this from an article which I wrote, some chapter I wrote. Let me see how I can make this full screen. Yes. So essentially, it's, like I said, it's triggered by certain organisms. The most common, of course, are viruses. The most recent, of course, being SARS-CoV-2 virus, which had the COVID epidemic. And there were lots of cases of GBS at that time. Other viruses are Epstein-Barr, CMV, and many others. I won't go into those details, but even bacteria, and the most common is this particular one. It's called the Campylobacter jejuni. Now, there's this basically molecular mimicry between the antigens on the bacterium and the nerve, and that molecular mimicry we'll talk about. So let's look at this Campylobacter. It triggers an immune response, and through the antigen process by cell, then the activated T cell, then finally the B cells start producing antibodies, and these antibodies then go and attack certain parts of the nerve. So the AMAN variant basically attacks the node of Ranvier, which, as you know, is that part which is unmyelinated. In the sense, it is between this, it's the node of Ranvier, and that's where it attaches. It uses complement, etc., to sort of damage the axon. While in the AIDP, the same antibodies basically have unknown targets. So over here, there are well-known targets in AMAN, anti-GM1 and anti-GD1A, while in the AIDP, the targets are a bit fuzzy over there, but they are also gangliosides, and they attack the myelin. And that's what causes either axonal damage in AMAN or demyelinating injury in AIDP. Now, you asked me about how does it present and all this kind of thing. So I'll just tell you, there are certain criteria which we use, and all of you know what the usual things of GBS are. So there are some of the criteria which have been, arrived by the consensus groups. So if you have acute onset of bilateral, relatively symmetric flaccid weakness, with or without involvement of respiratory or cranial nerve innervated muscles. So that's the first and most important. All of you know this. You need to have decreased or absent tendon reflexes, though in AMAN variant, it may not be absent initially, but it becomes absent very, very soon. It's usually a monophasic illness pattern, and it reaches, like you asked, the natural cause. So this basically, the AIDP is a much slower kind of, course than the AMAN. The AMAN can come within hours to a few 1 or 2 days, and involves respiratory muscles very early, and you'll end up on the ventilator much more with the AMAN variant. While in the AIDP, you sort of peak at about 2-3 weeks, maybe 4 weeks maximum, and then you start improving after that. And then, of course, the nerve conduction changes which occur with GBS. Usually, there are some early changes in the first 48 to 72 hours, but they may be as delayed as the second week. And even the same thing associated with CSF, high protein also may come up as early as 2-3 days, but may be also normal till the first week is over. And the final thing is, of course, absence of an orthogonal diagnosis. And then there are certain levels. So how sure you are whether this is a GBS or not. Now, one of the problems with GBS is that, like I mentioned, the diagnosis is purely clinical. You really can't. These things which I mentioned, the nerve conductions, CSF, etc., as you know, may be normal. So, is there any other method? And yes, all of you know that the contrast MRI spine will show enhancement of the ventral or motor roots. Now, understand that GBS is a radiculopathy and a neuropathy. Radiculopathy earlier, and that's why you get a lot of proximal muscle weakness. That's why you get increased protein, because as you know, the roots are basically bathed in the CSF, and the inflammation therefore will increase the protein. That's the reason you get a high protein. So this enhancement is seen very clearly in the first 48 hours and almost 90%. And that's why if you're not sure, you can do if the nerve conduction doesn't help you, if you're not sure of the clinical diagnosis or it's atypical or whatever, you can do an MRI spine, but it's not generally required in all cases. Okay, then what makes you doubt the diagnosis of GBS? And I think that's important. One is marked persistent asymmetry of weakness. So it's very difficult, if you're only right lower limb affected. You may have some asymmetry transiently, but it's extremely unusual to have marked asymmetry all the time. You may have bladder bowel dysfunction just for a couple of days because of autonomic nervous system involvement, but you will never get it for a long time. So if you have these two things, you must think of the spinal cord as a major differential diagnosis. The sensory level, etc., is difficult to do, especially in young kids. So the first two are important things to realize. If you have asymmetry or you have bladder bowel dysfunction, you probably may be dealing with a viral myelitis or, some transverse myelitis or something of that sort. Then if you have severe pulmonary dysfunction with limited limb weakness at onset, so if you have acute respiratory failure, I've seen a case actually who actually came as an acute respiratory failure, walking. He didn't have any limb weakness, and only we admitted him in the ward, developed cyanosis and all that, was intubated, and the next day he was quadriparetic. So he was AMAN, and in fact, he presented only as an acute respiratory failure. And then there are severe sensory signs. Fever is usually not there at the onset. Increased number of mononuclear cells can be there in HIV-associated GBS, but otherwise it's generally less than 50, and polymorphonucleus. So these are the kind of things which you can see. Now, somebody asked me about the variants. Can I go on, or should you ask me a question again?
Please go ahead, sir.
Yeah. So these are the atypical variants. One is the polyneuritis cranialis. So there's no limb weakness, there's nothing, there's only cranial muscle and cranial nerve involvement. So you may have ophthalmoplegia, you may have facial palsy is very common, as you know, in 50%. You may have bulbar palsy. The ophthalmoplegia is not the most common, in fact, except in the Miller-Fisher variant. I forgot to mention that the Miller-Fisher variant is also part of the GBS, and that affects basically the eyes predominantly. So you get pupils are normally reactive, you get ophthalmoplegia, and sometimes you may have other cranial nerves also involved, and only you have polyneuritis cranialis. Then this what is called the pharyngeal cervicobrachial variant, which we had an epidemic just last year. We had about 4 or 5 cases. All were AMAN, in the sense they were all axonal. It took a long time to improve. And they came like a descending paralysis. So they came with initially problems with dysphagia, and then upper limb weakness, and then respiratory muscle weakness. And in fact, the leg weakness, in one or two of them, it progressed to a full-blown GBS. In the other was, they continued to move their legs, but of course, they were weak. Then there's this Miller-Fisher syndrome GBS overlap, so-called GQ1B syndrome. So there's different antibodies you have, GQ1B, GD1A, etc. The GQ1B, the antigens are mainly in the eyes, and therefore you get the Miller-Fisher syndrome. And then this sometimes also has, besides, as all of you know, a Miller-Fisher syndrome doesn't really have much of problems except ataxia, areflexia, and ophthalmoplegia, with pupil reflexes being normal. Though occasionally they can be abnormal, but usually normal. And the GBS, of course, is a limb weakness. But sometimes you have something which starts off as a Miller-Fisher, and then you get a GBS overlap. The other three, which are the AMSAN, which is acute motor sensory, acute pandysautonomia, pure sensory variant, you can forget because these are extremely unusual in pediatrics. One which is very useful is the painful variant, which you should know. So they come like entalgia, hardly any weakness, and they come with a lot of pain. And one of the classic signs in GBS, if you want to differentiate, is you do the straight leg raising. In my experience, almost all patients will have straight leg raising test positive. So because the roots are involved primarily, and when you do that test, you get a lot of pain. And sometimes you may have only inflammation causing pain and not much of weakness, and you might think it's some non-neurological problem. And finally, you have the locked-in syndrome, which looks like the patient is in a coma because the only thing he can move is his eyes. Everything else is stopped moving, and the patient looks like, so you have to, this is a difficult diagnosis. But if the eyes are usually spared, so you lift up the eyes and you see if he obeys your commands, following your finger or something of that sort. Now I've given a list of the differential diagnosis. So you have, of course, in small babies, how do you differentiate weakness from ataxia? You may have acute cerebellar ataxia, and they also stop walking very fast, but they will keep moving their legs in bed, which is not the case in GBS. So in young children especially, sometimes it's difficult to differentiate ataxia from weakness, and of course, entalgic conditions. So anywhere you have pain, which can mimic GBS, and I've had this sometimes experience of a patient who had acute diagnosis of acute GBS, who actually had leukemia, and he had severe pain, and it was touching was tender, and everything was, and he stopped walking, and he was thought to be GBS. And then, of course, these myelitis, you must understand the non-polio enteroviruses, the most important ones over here. And maybe you should think about VAP as well. Sometimes vaccine-associated pediatric polio might come, especially we had a recent patient who was 15 days after the neonatal, polio virus vaccine was given, he developed this asymmetric leg weakness. So this is the kind of things you get. Acute transverse myelitis, is usually more obvious in older patients because there's a clear sensory level, persistent bladder, etc. And the rest are unusual in children: myasthenic, snake bite, botulism, etc. And the last thing I tell you is when to admit in the ICU. Because this is an important thing for residents to know if you see somebody in the casualty. So somebody who is rapidly progressive, morning he was, standing or walking, and evening he's not, you better admit him fast. Bulbar weakness, because that again is something you can call aspiration. Shoulder shrugging is very important. So you make the person do shoulder shrugging, and if the person cannot do it or is very weak, then that means your segments which are involved are the high cervical segments, and you're about to go into diaphragmatic weakness. So the patient is probably going into respiratory failure. Autonomic instability, all of you know, blood pressures, tachycardias, bradycardias. But remember, when you manage them, please don't use short-acting beta blockers if there's hypertension, because the blood pressure can suddenly plummet down. The same way you can use fluids and all that stuff to increase the blood pressure if there's hypertension. Then all these things are the 20, 30, 40 rule. I just mentioned as a theoretical thing. I don't normally use it because most of our kids can't do these things and we don't have the, it's difficult to do them. But if you have forced vital capacity, the inspiratory pressure, maximum inspiratory pressure, maximum expiratory pressure, all the figures which you can use to decide whether the patient needs to go into the ICU. The patient is old enough to cooperate. I use a very simple thing, single breath count. If it is less than 15, you better keep him in the ICU. Don't ever use ABGs because ABGs change late. The only time oxygen saturation may help you is when the child is sleeping. Because if it goes down at that time, that tells you that the patient is probably going into a respiratory failure. So I think this is what I just made kind of, and I'll just stop sharing. If there's
Thank
any
you
other questions, please go ahead.
for that detailed and very useful clinical overview of GBS. Let us invite Dr. Mandar Deshpande, the acute care specialist and intensivist, to further guide the general pediatricians for the early approach in the suspected case of GBS, how to rapidly evaluate and what are the early management priorities and where to refer. That's the key question. Mandar, can you please enlighten us about that?
Yes, sir. Thank you, sir. It was a very elaborate presentation by legendary Udani sir. So most of the things are covered. But how to approach a suspected case of GBS? Now, if you suspect a case of GBS, it is to be clinical diagnosis is the must. And secondly, the only thing which you have to see is the whether the child requires ICU admission or a ward admission. Admission is generally mandatory. And mostly if you see that if the child is able to cough properly, if the child is able to handle the secretions, if the child has, as sir suggested, shrugging of the shoulders, or maybe is able to move the shoulders up, the joints up of the upper limb, if the child's respiratory rate is normal, generally GBS will present with more of a tachypnea to begin with and then go into bradypnea or apnea later on in the further stages. Whether the gag is present and involvement of cranial nerves. This will decide whether the child has what type of severity of the GBS is there. And as sir suggested, mentioned that it may not be a reflexia to begin with. It can be a hyporeflexia to begin, and then at the nadir, many patients get areflexia. We have seen cases of Miller-Fisher coming into our ICU most of the times, difficulty in just walking, and they have cranial nerve involvement. They are not able to have proper swallowing and diplopia, antosis. Many of them will have ataxia, but many of them don't also have ataxia, and they have what you can say hyporeflexia to begin with. They have reflexes, and then later on, maybe after 2 days, 3 days, we see that the reflexes go down. So in this scenario, admission to ICU is must, and we should not rely on ABGs. As sir mentioned, it has to be a clinical judgment. If there is a paradoxical breathing, if there is a head bobbing, if there is a diaphragmatic weakness, if there is a single breath count which is falling gradually, if it is more than 10, then we are very sure that patient won't require ventilation. But if it is less than 10, single breath count is a very good indicator clinically to know that whether the elder child requires ventilation or not. And intubation in GBS is always should be taken, what you can say, a little liberally, because most of them rapidly progress. We have seen cases which progress rapidly. If they're not able to maintain the airway, there is a lot of pulling of secretions, and there is a respiratory, disordered respiration. There is a lot of sweating. There is autonomic dysautonomia, like sir mentioned, when there is a lot of sweating, when there is a hypertension. All these, I manage most of the patients in ICU. So most of the patients in ICU with GBS have dysautonomia. Almost 2/3 of them will have dysautonomia, autonomic dysfunctions, and most of them have hypertension to begin with. And as sir suggested, the hypertension is generally transient, but most of the times we use a short-acting drug to control that hypertension. And many of them will have a lot of sweating also. Few of them will have hypotension, will require fluid management of the hypotension, and few of them will have bradyarrhythmias. So if they have bradyarrhythmias, few patients may require pacing or so, but we have not done it in our center to begin with. I think if you have a decent ICU to begin with, if you have a ventilator with you, if you are able to manage the airway, you should admit GBS with you. And if you don't have these facilities, GBS needs to be carefully transferred. If the airway is patent, you can transfer it with oxygen and supportive care to a center where ventilator and PICU is available. And having said that, milder GBSs are managed maybe in the semi-ICU wards or maybe in the general wards also. But vigilance is very important. Vigilance is very important. You cannot try on GBS if the airway is not maintained and if the cranial nerves are involved and inability to move the upper limb properly. These patients generally require ventilation, so they should be transferred properly if you don't have that. And if you have that, I think elective ventilation will be required in many cases. And the most important thing is that once you suspect GBS, you should confirm it. One is clinically, and second is the other findings which we support with GBS. Maybe GBS in first week of presentation won't have a CSF albuminocytological dissociation. It comes in the second week of GBS. And if the patient is admitted and the onset of progression is rapid, so maybe in 12 hours, 24 hours, you see that the child has a neurological deterioration. These patients will definitely require ventilation, and have a tendency to become more sick. And as sir suggested, NCV studies, they will tell us whether the latency is delayed and whether it is an axonal involvement when the amplitude is delayed. And generally, in my practice, I have seen AIDP and AMAN most of the times AMAN rather than AIDPs. And AIDPs, AMANs are really very difficult to manage in small setups. They need a proper ICU. They need a proper neurologist care and a proper intensivist care. So if it is AMAN variety, don't play with AMAN variety if it is there with you, and refer it properly. AIDPs generally respond well to immunotherapy, but AMAN takes a longer time and they recover very gradually. So this is my experience about GBS. And as sir suggested, when it's chance they do a MRI spine will give us diagnosis. That is, if there is a contrast enhancement of the cauda equina, or if there is a contrast enhancement of the ventral nerve roots or maybe posterior nerve roots. Ventral nerve roots or the anterior nerve roots are mostly motor nerve roots, and the posterior are the sensory nerve roots. If there is a contrast enhancement, maybe enhancement of the cranial nerves can be picked up on MRI. So this all will tell us whether we are dealing with GBS or not. And for practical purposes, once you say that it is a GBS, the priority will be managing the airway and starting on immunotherapy. And better to start it early, because once the time you move on, my experience is that I routinely give immunoglobulin 2 gram per kilogram. And once I establish the diagnosis over 2 days, there are various theories to give 400 mg per kg or 500 mg per kg or 4 to 5 days. But as per the reviews, Cochrane reviews also, 2 gram per kilogram over 2 days is what I feel is better, superior, easy to give, easy to administer, except for the volume. If it is too much of volume, then you have to maybe give a little slower. Try to give IVIG as early as possible. Plasmapheresis, I feel it is not recommended or maybe not a standard care, because every institute will have their own policies of plasma. Secondly, it is an invasive procedure. A lot of hemodynamic instability with plasma exchange, and cost, technical problems in small setups. I think IVIG is very, very easy to give. It is what you can say a pediatrician or a pediatric intensive can easily give it with the proper monitoring. And we have to monitor the patient throughout for airway. And if you feel that patient requires intubation anytime, don't delay it. Airway patency is important. Loss of airway reflexes will cause aspiration and will cause nosocomial sepsis, and that will cause more and more problems. Autonomic disturbances, sir suggested, we generally don't treat as, except for the hypertension, or if it is with the smaller like drugs which are short acting, and hypotension, IV fluids, and similarly manage the patient. Ventilation in GBS is a very simple process to start with. Weaning is absolutely difficult. Weaning is difficult, but starting ventilation is very easy because it is a normal lung ventilation. If there are no atelectasis or no aspiration as such, we generally give PRVC mode or a volume control mode. Any mode you can start with. Start with the oxygen which is required to maintain the patient's saturation, and good tidal volume, maybe 8 to 10 ml per kg of tidal volume with a normal PEEP because it is a normal lung. And generally, while you wean them off, you have to be very cautious, because once you intubate, I think we should keep them for 7 days at least, because you start on IVIG, you see how the IVIG responds, how the patient responds. It takes 7 to 10 days. Maybe at the end of 10 days, if you feel that the ventilation is still required, many of us will go for tracheostomy rather than keeping them on endotracheal tube. But having said that, after 2 weeks, most of them reach a nadir and they start gradually improving. So this is what we do routinely in our acute ICU care regarding GBS. There is no role as such of steroids, though theoretically they decrease inflammation, but there is no role proved. And Cochrane reviews also say that it is not required in acute AIDP. Maybe if the AIDP is not improving after 4 weeks, 8 weeks of therapy, maybe if you require a second IVIG, if it doesn't improve after 4 weeks, in those situations when we think of acute onset of CIDP, in that case, maybe sir will elaborate whether the steroids are required or not. Most of the times, prevention of nosocomial sepsis, maintenance of airway, maintenance of ventilation, maintenance of circulation, proper pulses should be felt, urine output should be adequate, and just revisiting the patient again and again in ICU and looking for improvement in the motor power is what we think. And if the patient is able to wean off, weaning has to be very slow, especially in Aman variety of GBS. And because if you hasten it, you will land in problems. So it needs to be done very slowly.
Thank you very much, Mandar, for that review of high quality critical care, which is most important for outcomes in cases of GBS. Rajesh sir, your advice about the specific therapies and the course, natural history, and the outcome, and some prognostic red flags, just to keep in mind to advise the patient.
Yeah, I mean, I agree with him 100%. IVIG is the way to go. There have been several studies which are old now, which have shown that plasma exchange and IVIG do not have any, I mean, they're basically the same. Some people use plasma exchange, especially in older patients with a more rapid course, like that is becoming the kind of trend in other immune diseases, because plasma exchange, at least in, for example, in other immunological, neurological diseases, but as yet that has not been shown to be more advantageous. Therefore, most of us are using IVIG, but in a very heavy patient, maybe adolescent, where the plasma exchange is not something which is difficult to do, because the cost of IVIG looks like go into a few lakhs in that situation. So in that case, you could use plasma exchange. About the steroids, there have been studies quite old now, which have shown there are you cannot use steroids alone. Absolutely right. You may worsen the patient. But in situations, people have used methylprednisolone. In fact, there was a randomized controlled trial where they used, this was somewhere in the 90s, where they used methylprednisolone followed by IVIG, or both given together. And they showed a slightly better response in those who were given steroids and IVIG, but didn't reach significance, and therefore it was never repeated again. I use steroids orally because one of the biggest clinical problems which you face in GBS is pain. So the radicular pain, even after you've given the IVIG, the pain in the legs and movement makes it difficult to sleep at night, and they're sometimes miserable. Now over here, if you give a short course of oral steroids after the IVIG, I'm saying it again, after the IVIG, a short course of low dose, like a 7-day kind of fast taper steroids, it helps a lot if gabapentin or pregabalin or those kind of drugs don't work. Otherwise, generally, I agree that steroids are not got no role. About those patients who don't improve. So one thing you should remember is that when you give IVIG and all that, there are treatment-related fluctuations. So these fluctuations are well known. They don't mean that the patient is not going to respond, but sometimes they appear a little worse and sometimes they appear a little better before they stabilize and they start improving fully. So one should not jump into giving some other therapy. Many people, use IVIG, like Mandar said, after 4 to 5 weeks to see if the patient is not improving. And sometimes that's really a problem in AMAN. So you almost wonder whether somebody had asked a question, does AMAN, IVIG work in AMAN? And the answer is probably yes, because the prognosis of both AMAN and AIDP at the end of a year are more or less similar, except that you may have a couple of things, deficits in AMAN, like for example, you may have a foot drop, which might last a little longer. Otherwise, generally, even though AMAN looks like it's not responding, it is actually responding. It was given very early in the AMAN group. You might even prevent the worsening which occurs, if you give it a little later. The second dose of IVIG, recently there was a randomized control trial which showed that it didn't help. So there was, unfortunately, they didn't find any difference. And again, giving plasma exchange and then IVIG or IVIG and then after a month plasma exchange again didn't help. So even though unfortunately, there are certain patients who just don't improve. So in that situation, now people are using things like eculizumab. So eculizumab is a new it's a monoclonal antibody which acts against anti-complement. And there have been trials in adults. Of course, very expensive. It's not being used by us generally, but this is something in the future which might help. The prognostically tell them 90% if you can support them, and if you have somebody good as Mandar Deshpande to manage you, there won't be a problem because you will most likely go home. And after a year, you'll be back to your normal things.
Thank you very much, all the experts, Rajesh sir, as well as Mandar and AJ, about giving us just to conclude the subject of GBS, let me remind the audience that notification of suspected GBS as acute flaccid paralysis case to the local authority is a must, and please don't forget that. With conclusion of the first topic, let us now invite our second expert, Dr. Chandramohan Kumar, for introducing us and telling us the basics of hemophagocytic lymphohistiocytosis, the second immune complication which usually follows the infection. Welcome, CM Kumar.
So thank you, sir, for this opportunity. And I really thank first AJ, because he has just set the ball rolling by giving us the immunological process. As we call, there is a hierarchy of diseases. In the hierarchy of diseases, it starts trauma, deficiency disorders, infections, then comes immunological disorders, and lastly it goes genetics. So we are now moving from infectious disease to immunological disorders. So coming to HLH is a complex condition, and I believe we should understand HLH well, because this is a prototype of all sorts of in immunological conditions occurring in different organ system, because it's a multi-organ dysfunction system. So this is an excessive response to immune cells to a specific trigger. So a trigger may be anything, but due to a specific trigger, we can have an immune cytokine storm, and those storm takes everything by storm and goes into various organs and does this. So there is multiple cytokine releases are happening, and as the name suggests, hemophagocytosis. So hemophagocytosis seen in 100% cases, it's present in only 20. It may be absent. So that's not one of the sine qua non of it. So coming to the triggers, as Dr. Ankur has already told about the perforin and the familial primary, so we will focus on the other causes, and in the other causes we will make a passing reference of immunosuppression, organ transplant, primary immunodeficiency like Chediak-Hegacy, Griscelli syndrome, and X-linked lymphoproliferative disorder, and malignancy, leukemia, and lymphoma. But we will focus on infectious triggers. So infectious triggers, the list is increasing by every year, and now we have certain conditions, most likely the viral conditions. EB virus, as I remember that Pramod sir, you asked which of the viruses, which of the organism is most notorious for immunological triggers. These EB virus, this is the most important. It's causing everything. It's causing AIHA, it's causing aplastic anemia, it's causing HLH. So EB virus, CM virus, cytomegalo, varicella, measles, hepatitis A, and hepatitis C. These are also common viruses which may start the HLS process that trigger. Among the bacterial diseases, tuberculosis and brucella are the important bacterial causes. And among parasitosis, that's leishmaniasis may lead to HLH, and fungi, all sorts of fungi are known to cause HLH. So these are the triggers. Now, if you go with the pathophysiology, as we have already known, the chief defect was non-functioning of NK cell and CD8 plus T cells, because these cells were given the responsibility of removing that these cells had the role of removing all the intercellular organisms. So going to this, you can see this intercellular organisms, once they are not cleared, either due to T cell or dysfunction or NK cell dysfunctions, they consistently stimulate the immune systems, and the immune systems, which leads to further release of cytokines. So what has happened? So some people may have genetic predisposition for the macrophage hyporesponsiveness, and others, it's failure of the cytolytic function of the NK cell and CTL. This is persistent antigenic stimulation, and that stimulation leads to failure to give the apoptotic signals. So once the war is over, now the soldiers should go into the barracks. This does not happen. So the soldiers, the apoptotic signals for the immune system does not comes, and there is persistent proliferation of T cells and macrophages. So once the T cell and macrophages are persistently proliferated, there is a escalating production of cytokines, that is a cytokine storm. And these TNF alpha, interleukin 1, interleukin 8 cause havoc. So they will start having non-remitting fever, endothelial activation, CNS demyelination, hepatic lipogenesis, where we will have the increased TGs, triglycerides, and inhibition of lipoprotein lipase enzyme happens. Then infiltration of the HLH, those hemophytic macrophages, in the bone marrow. And there they have a bone marrow that cytopenias they will do, and infiltration to liver, they also have the coagulopathy. So by they affect almost every organ system. If we go into clinical features, so the cytopenias will be there, anemia, jaundice, lymphadenopathy, hepatosplenomegaly, and polycystitis, ascites, pleural effusions, then petechiae, purpura ecchymosis. So this will be the main presentation, and the patient will finally land up with the shock. So any patient who is having an infectious background and then comes with persistent fever, easy bruisability or mucosal bleed, and the mental state changes and seizure, because the demyelination is also happening, and respiratory distress and oliguria, oligemia, we must think of HLH. So if we have gone to HLH, then for investigations and how we can make our diagnosis. So the routine investigations, CBCs will have cytopenias of mostly of the 2 cell lines. There it must be there. ESR should be decreased. Normally in infections, you get ESR increased. Here ESR is decreased. Serum ferritin level is high, more than 500. As Ankur told, for the MAS, they have put a cutoff 684. I don't know why they have a specific cutoff. So it's more than 500 for HLH. And transaminases, AST elevation, serum fibrinogen is low, and triglyceride is high. So in the biomarkers, now we have the soluble interleukin 2 receptor alpha biomarker, that is all called CD25. So that's more than 2500 units per ml. So for a diagnostic criteria, there is a criteria that is called 5 by 8. Out of 8, 5 must be present to call it a HLH. So first is fever, then splenomegaly and cytopenias. So 2 cell lines must be affected. Then hyperferritinemia, that serum ferritin level should be high. Hypofibrinogenemia, that's 5th point. 6th is high soluble CD25, that is more than 2400 unit per ml. 7th is hemophagocytosis in the bone marrow or spleen or lymph node. And the last 8 point is absent NK cell activity in the flow cytometry. So out of 8, if 5 are present, we can diagnose a case as HLH. Okay, sir.
Ankur sir, your views about the diagnostic criteria currently applicable? Because there are many revisions of the protocols 2014 and all those. So what are the currently applicable diagnostic criteria for?
Sir, so you mean to say the diagnostic criteria for HLH, right, sir?
Yes.
Sir, the diagnostic criteria are the same as Dr. Chandramohan just enumerated. There is very important, diagnostic criteria for primary HLH especially is presence of a genetic mutation. Like if a patient has a genetic mutation, then they do not need any other criteria to, diagnose them as HLH. I mean, they are into a state of HLH all the time. Even if they don't have, florid cytopenia or fever or anything. So that's another important criteria. Now, for diagnosing secondary, HLH, especially when we talk about HLH or macrophage activation syndrome occurring in the settings of autoimmune diseases, especially systemic juvenile idiopathic arthritis. Now, there are different set of criteria. So the one that was formulated in 2016 by some of our colleagues from Italy. Dr. Angelo Ravelli was the lead author in that. The difference is, when you have a ongoing hyperinflammatory conditions such as systemic juvenile idiopathic arthritis or, for example, Kawasaki disease, and you have to diagnose macrophage activation syndrome or HLH into those diseases, you have to remember that in these conditions, platelet count at baseline is very, very high in systemic juvenile idiopathic arthritis or in Kawasaki disease. And when these patients tend to develop macrophage activation syndrome or HLH, you don't wait for the routine HLH criteria to fulfill. So for example, if my patient with systemic juvenile idiopathic arthritis comes with a platelet count of 6 lakh, and in next day the platelet count comes down to 3 lakh, I will be very, very suspicious that this patient is developing macrophage activation syndrome or HLH, and I will treat as HLH, even though this patient doesn't have thrombocytopenia. Now, so this is the basic, way to kind of diagnose HLH in the settings of autoimmune diseases. The similar way, the similar criteria is for fibrinogen, because fibrinogen in these conditions are at baseline very, very high. So you don't want fibrinogen to fall to the level that has been mentioned in the criteria for HLH. And even a slight fall in these values is very, very suggestive of an upcoming macrophage activation syndrome or HLH.
Rightly raised query by Dr. Jayan Joshi. We practitioners usually see HLH following the common infections like dengue, enteric fever, chikungunya, which are the concern for us rather than the typical
Yes.
MAS complicating rheumatological disorders. So the classic
Got it, sir.
differentiation between the genetic or primary and secondary, and amongst the secondary MAS in rheumatological disorders or post-infectious, is there any different outcome related or therapy related differentiation between all those four categories?
Okay, sir. So when a patient comes to me for the first time with HLH, and the patient has landed up in full-blown hemophagocytic lymphohistiocytosis, it's very important for me to understand if it is primary HLH or secondary HLH, because the management is entirely different. So there are certain clinical pointers and laboratory pointers that would suggest if it is primary HLH or secondary HLH. So the two clinical pointers that I would be very interested is in age. Especially if an infant or a very young child is presenting with HLH, I would strongly think of a primary HLH. Now, having said that, it doesn't mean that the primary HLH cannot present in later age groups. We have seen HLH, primary HLH, because of the genetic mutations presenting in the second as well as in the third decade of life. But most often, if you have a young child presenting with full-blown HLH, I will think of primary HLH is the first possibility, and I evaluate for primary HLH. The second thing I would look at very carefully is a family history, and that itself can sometimes give me a clue that, okay, I'm dealing with a primary HLH and not a secondary HLH, as was the case that I showed in my presentation. In one of the cases, that young boy who presented at the age of 6 had lost his brother at the age of 6 months because of an unexplained illness. There, I had a very strong suspicion that this could be a familial HLH. In the laboratory investigation, a basic criteria that we always teach our residents is primary HLH will not have a very high ferritin level. On the other hand, secondary HLH, for example, caused by dengue, or for that matter, any other infection causing HLH will have a very, very high ferritin level going into 50, 60, 70,000. On the other hand, primary HLH will have a ferritin around 4,000, 5,000, sometimes even normal. So that's a very important laboratory investigation to differentiate. If you have presence of neutropenia at the onset, I mean, that again is a very strong pointer towards primary HLH. So these are some of the clinical and lab pointers that makes us feel that whether we are dealing with primary or secondary form of HLH.
Looking into the therapeutic aspect, what we have seen,
Right, sir.
Practitioners, it's a spectrum. HLH is a spectrum of severity, and what we routinely see post-infectious HLH, they are really mild. Many of them are mild, and usually the issue is that most of them settle over time without any specific intervention, or may need a milder intervention. May I know from the experts here, Dr. Mandar as well, Dr. Chandra Mohan Kumar, as well as EJ sir, your take on the therapy of HLH, which we routinely come across.
Sir, you are absolutely correct. Even we deal sometimes a enteric fever presenting with HLS. We have confirmed it as HLH, but we don't need to do anything else. Only the primary care of the antibacterial treatment takes it. But sometimes, if the HLH is caused by the EB virus, in those conditions, you may have to go for the chemotherapy for the etoposide is to be needed. Otherwise, if the patient presents with the very severe conditions, so IVIG plus antibiotics. Otherwise, or if not that severe, so you can have steroids plus like methylprednisolone you can go, or the dexamethasone you can go continue with the antibiotics. You have to categorize it. Some patients, you need only antibiotic treatment. Some patients, you have the IVIG plus antibiotic treatment. And in some patients, where particularly is if you get the like EB virus and other conditions, where you have to go for that chemotherapy. And in the primary HLH, it's a different ballgame. Here, the chemotherapy is the mainstay. You start with the methylprednisolone pulse, and then we go on the chemotherapy that the Histocyte Society has the HLH regimen, so that we have to go for the long-term therapy. So I absolutely agree with your observation that the mild forms of the infection triggered can be taken care of by only the treating the infection. But we have to be mindful of the macrophages activation, and if needed, we have to go with the IVIG.
Mandar, your experience in HLH?
Sir, I do agree with the experts. HLH is again a clinical diagnosis most of the times. And we see patients which come to our ICU with, like, for example, enteric fever. And the fever doesn't settle after giving proper antibiotics. And even after that, the blood culture suggests the antibiotic, and you justify the antibiotics according to the blood culture. But the fever doesn't settle at all. Few of the dengue patients, we have seen that they recover, and then again at the time of discharge they start spiking fever, and this fever continues for more than 5-7 days. We get a splenomegaly. Fever is really very high. We get splenomegaly. We get again bicytopenias. We get a very high LDH. We get ferritin, which is most of the times high, and I think any ferritin above 1,000, one should be really suspicious about HLH. And you get SGPTs, which is high, and you get a more of hepatic infiltration of HLH. And in those scenarios, it becomes very dicey what to do. And what we do routinely is that we just observe for the fever for some days, and if it doesn't settle down, we do a bone marrow. And bone marrow, if it suggests hemophagocytosis in a very, what you can say, global manner, a focal hemophagocytosis won't justify it as a HLH. But if the hemophagocytosis are like more than 50%, 60% in bone marrow, then we do this fibrinogen, triglycerides, hypertriglyceridemia, hypofibrinogenemia, high ferritin, high fever, and then we justify it as a HLH. And we have to treat HLH. We can't wait for HLH to go on, because natural history of HLH in ICU is we have seen patients deteriorating very fast in HLH. And in that case, mostly one dose of dexamethasone, 10 milligram per meter square we give, and we see for the response. Maybe after we give 10 milligram per meter square for first 2 weeks, and then 5 milligram, and then taper accordingly. But most of them will settle down in 7 days with dexamethasone therapy, and we have to curtail the therapy accordingly. Most of the times we don't use etoposide unless it is a very florid variety of HLH and which is proved. And regarding HLH, I will have to also say that when you are using steroid for a longer time, you will have to keep in mind prophylaxis with Septran, and prophylaxis with fluconazole, because they again will have a risk of sepsis and deterioration in their further treatment lines. So this is how we do. Dengue, we see a lot of HLH patients, and enteric fever also, chikungunya also. Epstein-Barr, yeah, we have seen some patients of Epstein-Barr coming with HLH, but these are the cases we see in ICU, and they really deteriorate very fast if not treated well, and not anticipated and treated properly.
Ankur sir, your inputs about
Sir, yes, sir. I would like to add, sir. So I completely agree. Infection triggered HLH is something which is not very easy to manage, I would say. And as Dr. Chandramohan and Dr. Mandar said, when you see infection associated HLH, and if it is fitting into the criteria of HLH, I mean, it's very difficult not to treat. We occasionally, we start with IVIG. I mean, IVIG is not a very good treatment for HLH, and we always teach our residents the same. IVIG is not a very good treatment for HLH, but it buys some time for you to understand what's happening to your patient. And, in those 24 hours, you can make your choice. You can decide what needs to be done, and if you are in a position to actually give steroid. But if a patient with infection who is fulfilling the criteria of HLH, it is not very easy to leave that patient untreated. You have to start steroid. If we see this HLH very commonly with enteric fever, dengue fever. If the patient has to improve on its own just by treatment of infection, the patient will improve in 24 hours. If the patient is not improving, cytopenias are not improving, fever is not going, I think this is a time when you have to think that you need to treat HLH. most of these patients do respond to corticosteroids. The next line of treatment for these patients would be cyclosporin, but that's very occasionally you would need cyclosporin for these patients. But most of these patients would respond to just corticosteroids.
Rajesh sir, HLH is said to have neurological manifestations that too very scary also sometimes. In your experience, HLH giving neurological.
Yeah, I mean, I've seen a few isolated serious HLH in the sense you can get HLH without any signs of systemic disease. Of course, you get neurological symptoms also in any of the other HLHs also you can get because you get these demyelinating kind of lesions, the white matter lesions with sometimes evidence of hemorrhage and they mimic sometimes demyelinating disease. And in fact, because they respond to steroids, they're very often thought to be as ADEM. Nowadays, I mean, it's always difficult to, if everything is coming negative and the patient is not improving, to diagnose HL has always been a problem for me because I remember in the past, we had a patient we actually did a biopsy on because we thought of it, but there was no way we could diagnose it. The biopsy showed us HLH. And recently we had a patient, we did the perforin analysis and we found that it was reduced and then we followed up with genetics. But isn't there some other, I mean, the question I had for the hematologist was, do you have, CNS, isolated CNS, HLH, do you get it in infection associated or is that obviously not usually seen in primary HLH? You understand my question? That is it
Can I?
primary
Yeah, I can
Both of
actually.
the conditions.
Yeah. Sorry?
Sorry.
Yeah,
Oh,
Ankur, go
I
ahead.
think somebody was answering. Yes, sir.
So
Pramod, sir,
after
you
the
were answering.
come to or are you answering it, Ankur sir?
No, sir. I just wanted to just add to what Dr. Udani sir said. I mean, it's very uncommon for secondary HLH to only involve brain. If you have a primary CNS HLH, which is an extremely difficult condition to diagnose, most often the diagnosis comes from imaging, wherein the neuroradiologist suggests that, okay, I think this is unusual, could be, HLH. No findings in the hematological system, and then you tend to investigate these patients, and then they, by flow cytometry or by doing genetic tests, they may have perforin. We've seen syntaxin binding protein deficiency presenting with primary HLH. We've also seen X-linked lymphoproliferative syndrome presenting with primary HLH. So it's a difficult area to deal with, but I think these conditions are being increasingly recognized, where just isolated CNS HLH as a primary manifestation of familial HLH.
Yeah.
With the importance diagnostic and outcome wise importance of the primary HLH, do you suggest that at least in the severe cases of HLH, one should go ahead with genetic testing to rule out the genetic component or predisposition?
Yes, sir, in very young children, we must go and out. Otherwise, if there is a definite setting, adolescents and other children, we normally prefer to first investigate and take it as a secondary HLH. But in very young children, we go for it, sir.
Thank you. Coming back to Udani sir, apart from GBS, post-infectious immune neurological problems, few key messages, few key conditions from your side, sir.
Yes, I mean, basically there are lots of, in fact, neuroimmunology has exploded over the last 20 years. Before 2007, really people thought that central nervous system immune disease was restricted to ADEM, acute disseminated encephalomyelitis, which is a demyelinating disorder acutely seen in young children. But now we have the huge number of autoimmune encephalitis, which has I think from 2007 onwards, we're seeing a lot of them. And essentially all of them, you know, then of course we have cytokine storm syndromes like the fires syndrome, which comes with super refractory status epilepticus. And generally, the presentation of all these are similar, though with some key differences. For example, ADEM um, usually occurs in younger children. It uh, seems to come with either MOG antibody positive or MOG antibody negative. It seems to have, you must have an encephalopathy, you must have some focal deficits, uh, and you must have changes on the MRI typical of ADEM to make the diagnosis. And it's pretty simple, and treatment also is pretty simple. You basically give steroids, uh, and if in unresponsive cases, if it's a very severe cases, you give plasma exchange if possible or IVIG. But generally, most kids do well, and the second line treatment is given after about 7-10 days if the first line fails. And the steroid is, of course, the first line. But this in ADM itself, this MOG antibody positive is a new thing that has happened. And we all recognize that about almost 40-50% of patients with ADM will have a MOG antibody positive. And that means that these children can occasionally, not commonly, have multiphasic ADM, or they may go into other types of, rarely. In the older patients, you might go into optic neuritis and transverse myelitis and other types of recurrent demyelinating disease. The autoimmune encephalitis, if you want to just check one antibody, it's really the NMDAR, NMDA anti-NMDR antibodies, because the other ones are distinctly rare in pediatrics. There are some few ones. The other one is not common, but is sometimes seen as anti-GAD. And the difference between the anti-NMDR and the anti-GAD is that one is extracellular and the other one is intracellular. The third one which has been described is anti-GABA-A, which is presents like a status. But frankly, if you have an autoimmune encephalitis setup, which is essentially, there's not much of, there may be fever at the onset, but afterwards you get a subacute evolving illness consisting of an encephalopathy, mutism, speech disturbances, psychiatric disturbances, movement disorders, seizures, etc. Obviously, everybody will think of this, especially because many of these patients have normal MRIs or specific or non-specific changes on the MRI. And in these situations, the NMDR encephalitis seems to be a kind of prolonged kind of thing. So you need to diagnose it early, and remember, you have to do a CSF, because about 10% or so of the serum will be negative. So you need to do a CSF. The other interesting thing in NMDR encephalitis, they can follow other encephalitis. The most common one, of course, is HSV encephalitis, where you get secondary encephalitis caused by NMDA antibodies. And the point is, there's different, depending on how severe it is, to give first line treatment is, I give steroids and IVIG in those patients who are significantly affected. And then if it doesn't work in 2 weeks, we graduate to rituximab. If the patient can't afford, then cyclophosphamide. And after 3 months, if it doesn't respond, tocilizumab. And there are many newer ones which are being used. And the duration of treatment also differs. Now, the new recent international recommendations is that you give the mild ones about 6 months or so, the moderate ones, the moderate disease, which took a longer time to respond, about a year. And if it's a severe disease, you give it for up to 2 years. And this is, I think, the most 80-90% of your patients will do well. They look so terrible when they come in, but with proper management, they can really do well. The only thing I think about NMDR is, you should always worry about the autonomic symptoms. because they can sometimes in the acute active stage, they can go into hyperventilation. And sometimes you may end up with a mortality because it's not being monitored properly. So I think this is the one autoimmune encephalitis. And the third are these infection-triggered encephalopathies, which are now called ITES. And basically, these are the most famous of them is acute necrotizing encephalopathy, which is the ANEC or acute necrotizing encephalitis of childhood, which comes acutely with fever. And as the fever has not even come down, the neurological symptoms start. So it's not really a post-infectious, it's a para-infectious, and it's devastating disease. And the typical thing is non-specific symptoms of seizures, encephalopathy, etc., and high liver enzymes. But if you do your MRI, the classical features are bilateral thalamic lesions, which are usually symmetrical, which have hemorrhage, and which have some typical findings like a trilamina sign. So if you diagnose this and you give tocilizumab, which is a anti-IL-6 antibody monoclonal, if you give it within 30 hours or so, you can change the disease course completely. So I think that's the message that pediatric, but we never get these patients in the first few days. It's always a come as a, a week later, what do you think? What should we do? Give this. But if you people diagnose and your MRI radiologist diagnoses that you have a A&E, and if it's within 30 hours, please give tocilizumab. It works it works really well if it's given early, not later. So I think these are three. Fires, of course, is a different kettle of fish, and nobody yet knows whether it's really immune or something else. But even that one responds in some patients to tocilizumab and anakinra. So I think there's a lot of exciting things happening in neuroimmunology, and I'm sure more syndromes will be described soon. Thank you.
The hyper inflammatory syndrome or MISC has already been addressed by Dr. Ankur Jindal. I feel now let us open the stage for the question and answers. Dr. Chetan, can you please help me about the question and answer?
Yes. It was a wonderful discussion with quite eye-opener. Like literally enjoyed the session. Dr. Kulkarni has brought out very nice information from all these experts. So there are a few questions from in the YouTube also, and there are a few questions here also. I'll take from YouTube. Dr. Sujal Dave is asking, when is the earliest response expected or when to conclude IVIG non-responses in GBS? Any role of second dose of IVIG? I think you mentioned it, but can we just elaborate once more?
Yeah, so generally, in GBS, depending on whether it's a AMAN variant or an AIDP variant, is different. So within a month or so of the AIDP variant, you start seeing improvement. And generally, that improvement will take a few months. And by about 3 months or so, you're sort of mostly walking at least. In the AMAN way, of course, this depends on the severity also. So if it's very severe AIDP, that might take a longer time. AMAN variants might take a long time. They may remain on the ventilator for as long as 3 months, and they get a lot of comp. So basically, the key thing in AMAN is not so much the IVIG and all that. You give the IVIG, do all that, but the supportive care has to be absolutely first class, because they get a lot of complications of even, not moving. I had a patient who had developed hypocalcemia because of this and a lot of problems. So that is the thing. Second dose of IVIG is, you can give it, but at least literature now has confirmed that it probably will not work. But if there's nothing else to be done, patient is not improving, I think, see, remember one thing, literature always talks about randomized controlled trials, and you cannot apply it to a particular patient. So giving it, I think, is not wrong, but at least wait for 4 weeks.
Okay. There's a question from Dr. Gomti Srividya. How much time can we wait for the diagnosis of possible HLH with sepsis?
That depends on the normal natural course of the disease. So if usually by day 10 we start to think the first 5 days we don't think there is anything important. So by day 10 we start thinking in the line of HLH and we go with the inflammatory markers, and if needed bone marrow examination. That's in the second week.
And most importantly, as Dr. Mandar discussed, that bone marrow gives a diagnosis of HLH. A typical picture, usually it takes time
2 weeks.
to get a picture of typical HLH in bone marrow. Before that, I think we have to suspect the diagnosis. Maybe the child is sick looking, there's a bicytopenia, and patient is not recovering. In that case, you have high ferritin, and you suspect and you get a diagnosis. You have to start treating at that particular point. Maybe when fever of unknown origin, or maybe a prolonged fever, we go for bone marrow for diagnostic sake, then we may get the HLH. That's a different thing. Yes. Then one other question was
I think, Dr. Chetan,
Yes.
sir, sorry, if I may just add, I think bone marrow is in cases of HLH especially is more to rule out secondary
Yes.
causes.
Yeah,
For
correct.
example, malignancy,
Yeah.
you do culture,
Very true.
for that reason, it's extremely important. Yeah.
So it's very important message. It's not to diagnose the HLH, rather you just rule out the other things. Very true. And also there's a question that what antihypertensives of choice in your experience for GBS dysautonomia? Is clonidine preferred in your unit?
No, actually, in my setup, I do manage them with short-acting antihypertensives. Labetalol works beautifully. Hydralazine works beautifully. If there is a tachycardia associated with hypertension, maybe propranolol, and this should be fine. I don't routinely give clonidine as required.
Okay. There is a question from Dr. Jalil. Is there a special protocol for resource limiting setting just to buy sometime an empirical road of methylprednisolone during transport?
During transport of GBS?
Dr. Jalil, you have asked the question?
Yes, sir. Yes, sir. GBS only.
Okay, GBS. So any role of methylprednisolone while during transfer?
No, not really. GBS will give you time, except that the airway should be maintained. And maybe once you are very sure that it is GBS, you should rather start IVIG rather than methylprednisolone.
Dr. Jain, Joshi is asking. Yes.
IVIG we may not get, sir, but just to buy some time during the transport, will get benefit.
Actually, methylprednisolone alone may probably worsen the situation. And remember, the immunotherapy is not going to act immediately anyway. It's going to take time anyway. So actually, what is
Nothing
needed
is
in the
required.
acute stage is supportive care, ABC and all this kind of thing. That's what's needed.
Professor, sir, there is one question that is, in case of slow recovery of GBS or a refractory recovery, at that point of time, will us consider the biological, sir?
Yeah, that's what I said. Recently, there's been some lot of interest, in fact, in adult GBS, where the eculizumab has been used. But I don't know whether anybody is using it in pediatrics. I'm sure there must be off-label uses, but eculizumab is an anti-complement monoclonal.
Dr. Jayan Joshi is asking, does the chest fluoroscopy to check the unequal diaphragmatic movements, can it be done to anticipate a respiratory failure? Dr. Mandar?
No, we don't rely on that. It's mostly clinical, and even spirometry is not possible at bedside, and kids are not able to perform spirometry properly. So it's more of clinical, and basically intubation in GBS is to maintain the airway, to prevent aspiration, and to support respiration. So in doubt, I feel that we should go with intubation and ventilation when you feel that it's going to be like impending respiratory failure. Better to err on a more invasive method, that is intubation. Don't try on non-invasive ventilator, and don't try on doing fluoroscopy. Clinically, we can easily do it, and vigilance is important. Monitoring is very important.
I had a question, Dr. Deshpande.
Yes, sir.
Do you, prefer nasotracheal if it's a big enough, if it's an elective intubation?
Yes, sir. If it is elective nasotracheal, we do perform, because clearance of the secretions becomes little easy, and patient do cooperate well with nasotracheal intubation rather than endotracheal intubation, oral intubation.
Yeah.
And for a longer time, if you want to keep a nasotracheal tube is better managed, patient can open the mouth and it feels patient friendly rather than oral endotracheal tube.
Thank you.
Dr. Vinod Gandhi sir has put a question like, why do some of the patients have recurrent GBS? Is the management same?
It's a good question. You see it in about 5% of patients, recurrent GBS. And we had an unusual case where there was a familial GBS. So the first patient had and her cousin or somebody also developed a GBS. So I'm sure there are some genetic explanation for this, though I'm not sure it's available right now. But I think there must be some sort of susceptibility genes which probably make you more susceptible to these kind of immunological problems. I mean, I'm not sure we have found any of that. But you're right, it's recurrent. The treatment is exactly the same and the prognosis is exactly the same.
Okay. There's a question in a suspected MISC. Now, I think are we really getting MISC or not is the question. But in suspected MISC, if we get to do any anti-COVID antibody only after IVIG, how far it is reliable? So the
I
question
think we
which
should stop doing COVID antibodies pre or post IVIG any time. We should stop doing COVID antibodies now. I think in any patient,
because it will come positive.
All of us have COVID antibody. It will
That's
come
what.
positive. I think all of us have COVID antibodies. Yes.
So you can't really say whether it is because
treatment also doesn't change. So there is no need to do.
The antibodies are still, the titer might have gone down.
Sir, again,
Ankur,
in a research limited setting, just prior to transport, we are worried about the airway. In a research limited peripheral, the airway management is very critical and it is difficult. In that case, the laryngeal mask or anything that drive the respiratory muscles, like always in a neonate, we give caffeine. Like that, any stimulant or a laryngeal mask ventilation can help, sir. This is in a research limited setting, not in the design or perfect ICU.
Sir, you're talking about maintenance of airway in a resource limited setting. I think it's a very good question, but again, I will have to say that there is no stimulant to give for, like you have caffeine in newborns. You can't give that much in adults or pediatric patients or adolescents. Secondly, coming to laryngeal mask airway, yes, you can perform a laryngeal mask airway just to tide down the crisis, maybe for a couple of hours, for short process, like for transport. If you are not able to intubate, then laryngeal mask airway is a better option. But again, you will have to ventilate and then transport the patient.
I think we have completed the questions, and there are a few important clinical tips from Dr. Baldev Prajapati, sir. I think I'll request him only to come on the screen and say he has given. Dr. Baldev, sir, are you there? Yes, sir, he's there. Yes, sir.
Am I audible?
Yes, sir.
Yeah. I think really the whole discussion was quite interesting and even many points to learn for the general pediatricians in the daily practice. Somehow I think GBS, as already discussed in Pune, lot many cases, other places also somehow it is increasing. Probably, as Dr. Brajesh said, that we don't have the exact explanation. Some GI infections or some viral infections may be responsible. I think regarding the prognosis of predictors from the GBS point of view, which we have observed, that obesity somehow is really creating more problems in GBS. I think in a probably span of last year, we lost 2 children due to the GBS, and where they were quite obese. I would say weight was 70, 75. And compared to one other 2 children, or I will say which we can see, not exactly studied, but having the similar severity of the GBS, somehow they survive. And therefore, I think even mentioned in the literature also that nowadays, and you know that obesity is increasing and probably becoming the very bad predictor for many conditions like that or even for the GBS. Another thing, I think with the autonomous nervous system problems, even rapidly progressive GBS, somehow these are the, I would say, signals to keep in mind for the prediction point of view. And I think regarding many times being the teacher, it is very common for us, the question for the postgraduate, that you diagnose GBS in the OPD. You hospitalize, and when you probably hospitalize, mild manifestations, but yes, satisfying the criteria to diagnose GBS. How will you monitor such patients? And I think that is very important for all of us in daily practice. And I think all of us know the problems. And for particular respiratory, I think already point was in the discussion that always look at the tachypnea. Second thing, look even for this movement of the diaphragm. And third, very important one, note that this single breath count, if it is gradually, I think, decreasing, don't wait, as sir very, I think, appropriately advise us. The problems of acidosis and all the things are quite late. I think during that time, probably patient is already the critical stage. So for general pediatrician, I will say what we are practicing, better to observe them, but very classically, I would say temperature, which I am not expecting. But if really febrile patient, I think maybe the red signal sign. Hypertension, very important. Respiration, the way in which I said that we love to monitor. And paradoxical movement of respiration many times will be seen, I will say, rather than on the screen even or the fluoroscope it is to be seen. So I think these are the few points which I will say as a general pediatrician in our daily work we observe, and probably it is quite good. The rest of the things I would say fantastic we learn from all the learned, I would say, panelists. Thank you very much.
And I would like to have comments from Dr. Bala, sir.
Yeah, I mean, first of all, I'm just delighted to listen to all five of them. It was fantastic. Hats off to your brilliant exposition of a difficult subject. Okay, but I have a few comments to make. In fact, in the discussion, there is talk about IVIG cost. There is also confusion for general pediatricians on IVIG dosage. If the child is obese, as Dr. Baldev Prajapati said, many children nowadays are obese, don't go by the body weight and give 100 grams of IVIG. The maximum dose is 70 grams. So please remember, more than 70 grams, your IVIG is not going to work. There won't be enough antibodies to neutralize. So 70 grams is the maximum dose of IVIG. That's number one. Comment number two. Somebody was talking about COVID antibodies after IVIG. Whenever a general pediatrician gives IVIG, whether it is HLH or GBS, suppose you're going to transport after starting IVIG, please do one thing. Please take a 5 ml sample of serum, 3 ml or 4 ml of serum or whole blood, and preserve in your fridge. Because whatever immunological test that you do after IVIG will not be of any use. Suppose you order ANA after giving IVIG, it will be useless, right? Even genetic studies you won't be able to do. So please take a sample. This is very, very important, particularly in HLH. We always know that it is difficult to distinguish between primary and secondary HLH. But today in 2025, one can't be clinically sure it is primary HLH. You have to send an exome sequencing to rule out primary HLH, which is treatable with a stem cell transplant. Okay. Fourth comment, ferritin is a very, very useful screening test. And if ferritin levels are more than 10,000 in a child with bicytopenia who looks like having HLH, I don't think there is any other alternative diagnosis. In fact, we have in our institution seen 30% of our cases of HLH do not show bone marrow evidence of HLH.
Yeah.
But if they have ferritin levels at 20, 30,000, we don't wait for the reports. We straight away start treating it as HLH. Because you must have a good hematologist to tell you it's not malignancy, right? And last comment is, we are moving away from infection to autoimmunity, just like we are moving away from heterosexuality to homosexuality. In fact, there was a time when I had 10 patients as inpatients. Only one patient of mine received an antibiotic, and nearly 7 patients were receiving either IVIG for Kawasaki or for ITP, or steroids for asthma, or steroids for rheumatoid arthritis. So the number of times pediatricians, infectious disease specialists move beyond antibiotics is gradually going up. We are going to see more and more of such non-infectious causes. In fact, I'm sure Dr. Udani would agree. I think 30 years back, the number of cases of autoimmune encephalitis, number of cases of Mogad antibody encephalitis, number of cases of ADEM, I would have treated with prednisolone and 4-drug ATT instead of giving immunological therapy. I dread to think of those cases and the mistakes I made 3 decades back. Now we are wiser. And I'm sure at the end of it, we'll all be more wiser. Brilliant session. Hats off to all 5 of you. Thank you very much.
Thank you. Thank you, sir. Thank you, sir.
Thank you so much. It was a wonderful discussion. And may I request Dr. Darur sir, if he's there, immediate past chairperson, because this Super 11 series was started under his leadership. If he's there, I would like to have comments from him. Dr. Rangnath sir, Rangnath Darur sir. I think he's not available. Anyway, so I'll request our treasurer, Dr. Yashwant Rao, to thank everyone.
Thank you, Chetan Bhai, on behalf of Team PIDA. We did a last program, rational antibiotic therapy in OPD practice, moved away from antibiotics to most interesting topic, the most happening in Pune. We had moderator Dr. Pramod with Rajesh Udani sir, Madar Deshpande, Chandramohan, and Ankur Jindal for enlightening us for more than 1.5 hours, 1 hour 45 minutes. And with comments from seniors, it was really interesting and good to listen to all the legends. Thank you, one and all. Good night.
Good night.
Good night. Thank you so much, everyone. Thank you, Rajesh sir.
Thank you.
Thank you. Thank you,
There's
Baldev sir.
one thing, I think drop the sir now.
Good night, sir.
Thank you. Thank you.
Good night.
Thank you so much.
Good night.
Good night.
Good night.